Okay, so we'll continue talking about neuropathic changes. And here we can see a little bit of signal change within the some little edema on the T2 weighted images on these low field scanners within the supinator muscle. Thank you. The patient had radial tunnel syndrome. Okay, Elior, what do you think of this one?
Okay, so here along the lateral elbow, I see increased signal within an extensor muscle. Is that the extensor digitorum superficialis?
Okay, and here we can see it here. It's a little bit posterior, really, kind of in the midline there.
Mm-hmm.
And then so what we see here, if we go to the axial images, you can actually see the two muscles are involved.
Yes.
Second.
Not.
And hi, John. And one is the extensor digitorum, the other is the extensor carpulnaris tendon, posteriorly here. And that's got the medial branch of the posterior interosseous nerve. So this is, again, part of the Penn syndrome. Okay. And this is just from the literature showing the typical edema you can get here in the extensor tendons involved with the compression of the posterior interosseous nerve.
Are you there, John?
Yes, John, can you hear us? John, can you hear us? Elior, can you hear us?
Yes, I can.
You can?
I'm not getting your voice.
Hi, John. Dr. Yagutis is not hearing us, but other people on the car are. So somehow his voice is turned off. Thank you. Okay.
All right. 42-year-old female, slow progressive limitation of extension, first through fifth fingers on the right for a year. Previously undergone surgery and chemo for breast cancer. All right, so it looks like we have marked atrophy of the
John, can you hear us?
extensor muscles.
Okay, keep going.
Yeah, atrophy of those extensor muscles.
Okay, that's on the axial plane. If we go to the other planes, we can also see marked atrophy.
Yeah.
Here of the muscles. So a lot of the extensor muscles, which explains the patient's symptoms.
No, I can't hear him.
John, can you hear us now? So here again, we can see the posterior interosseous nerve as it goes back here behind the supinator, where it can be compressed anywhere along this area and then end up with involvement of the extensor tendons. Okay, usually it's compression, but obviously anything that could impact the nerve in those areas could end up producing it. So At MR imaging, this was 25 patients that they evaluated with posterior interosseous nerve. And as far as findings, isolated supinator edema was in about a quarter. Supinator atrophy alone was in about number of patients. Oh, well, 1 in 4, 8 and 32. Well, these are all a quarter of what's. I'm not exactly sure the numbers here, but so you can see that you can look for supinator edema, atrophy, the muscle edemas also in this syndrome. And it all depends on the location of the injury to the nerve as to what the findings are. Oops, let me see here. John, are you with us? Sorry, I'm getting a little distracted with John not getting on. John, did you make it? Can you hear us? John, can you hear us? Elio, are you still?
I'm having trouble with hearing you, John.
Can you hear me now? Elio, you can still hear us, correct?
Yeah, it's fine.
I couldn't hear Elior either.
Okay. Sorry.
Hello, Dr. Crues.
Yes, so it sounds like John still can't hear us.
Yeah, I'm already with him right now. We
Okay.
leave and now we join already, but we still can't hear you.
Other people can hear me, so it must be a problem. You must have the
In his
sound turned
computer.
off.
Okay, let me explore, doctor.
Okay, and then here it just shows the muscles posteriorly that are involved with this syndrome. Okay, let's move on to inflammation, and hopefully John's going to be able to hear us soon. So we can look at bursitis, foreign bodies, infection, arthropathy, and the different muscular dystrophies. So Elior, what do you think of this one?
Okay. 2 weeks of pain and swelling extending down the arm from the olecranon. I see soft tissue thickening in the
Okay,
posterior
on the plain film.
elbow. Yeah, on the plain
So,
film.
so do you want an MR?
Yes.
Okay, that's one cut of the MR.
So I see. I think it's is it a PD fat set on the right?
Okay,
And a T2 on the
actually,
left?
this is a T1 on the left and a T2 on the right. These are very old sequences.
Okay.
And then here we can see that there's actually this fluid collection here back in the area of the olecranon bursa, and this was olecranon bursitis. Okay. Robert?
Yes,
John, can you hear us now?
yes, I can.
Good. Excellent. Okay, great.
Okay.
Robert, this is Robert's case.
All right. So looking at the elbow, posterior to the ulna, looks like there's some soft tissue thickening back there. I guess it's decreased in signal.
Okay, so this is a T1, and an axial T2. These are studies were from around 1990. They're very old studies,
Yeah.
but it shows even with old-fashioned techniques, we can see abnormalities there. So what's going on here?
I mean, again, I'd be concerned for bursitis or even like a,
And the signal intensity, it's low on the T2, so it's not a typical just straight fluid collection.
maybe like a hemorrhagic bursitis.
Right. So this was hemorrhage, and I think that was from direct trauma. Okay. Similar symptoms in this patient.
All right, so
A number of different appearances of olecranon bursitis here.
T1.
Yeah, so this is
Not
a
very
T1 and an
revealing.
old-fashioned T2.
T2 maybe on the, that right
And
side of
on these old-fashioned T2s, fat's not usually this bright. So this is actually some fluid and hemorrhage that's extravasated from olecranon bursitis. So let's
see.
skip that. Let's go on to this one. Take this one.
All right. So it looks like we have some increased T2 signal within
Okay.
the
So this is T1 and this is PD fat side.
PD fat set, so increased PD fat set signal within those muscles.
So we have
Um,
here,
and then some
low
overlying, subcutaneous
Okay.
infiltration.
Okay.
Maybe a penetrating injury?
Okay, good idea. So there we see that. And what do we see here?
Is that a needle?
That's a thorn.
Is it thorn?
So
Okay.
this person was an avid gardener.
Compound.
Yeah. And this was actually many years ago in Santa Barbara. And there in the wintertime, you often get, or the fall, as we get the Santa Ana winds here. So you can get fronds from palm trees all over the place. And they have these long stickers about 4 inches long. And if you're not careful, they can end up here. And that's what it was here. This patient, it broke off and was irritating for a couple of weeks. And they couldn't find anything, so they finally we decided to try an MR scan. Again, this is a pretty old scan, and we could see the thorn, and we could see the little abscess around it, so that allowed them to go in and remove it.
I had a 6 months old infant or a 2-year-old, I can't remember. The, the pediatrician was treating the kid with antibiotics for about a year with swelling off and on. It
Yeah.
was in the knee though, the palm front.
Uh-huh.
So we went to surgery. This was before arthroscopy and
Yeah.
before MRI.
Yep.
And I was operated on the boy, and I'm just ready to quit. My partner says, "Oh, let's get out of here. There's nothing here." And I just saw some red stuff right in front of the meniscus.
Ah.
And I scratched a little bit, and out came the needle.
Oh my gosh. Wow. Okay.
And the boy was cured.
Fantastic.
If I would have listened to my partner, we would have been up the creek.
Right. Especially your patient. Okay, Elior, what do you think of this case from France?
Okay, so radiograph of the elbow, I see a deformity of the elbow joint,
Yeah.
destruction of the radial head, fragmentation, just, joint space destruction.
Okay. How about a CT here? Here's a CT.
I'm trying to catches my eye is this structure by the radial neck.
What's that thing in the radius?
Yeah, was that a prosthesis?
Okay, good. Yeah, and then I can see all these cystic changes, all these marginal osteophytes, and this is a case of silicone synovitis from an old silicone prosthesis that basically broke and was in there. They used to be used in the old days for recalcitrant rheumatoid arthritis. John, you want to tell us a little bit about it?
Well, we used to do that, use it all the time for a couple of years, and then we found out that it fell apart on every joint we tried, mainly in the hand, elbow, and feet. But they didn't work out. They didn't last.
Okay.
We did hundreds of them.
Wow.
All right, so we have a 78-year-old female. We have T1 weighted imaging up top, T2 on the bottom. Looks like on the T2 imaging, there is a, I guess, T2 bright lesion. Yeah, kind of right there. T1 intermediate.
Okay, this is from Korea. There's the contrast enhanced T1 fat suppressed.
Yeah.
Unfortunately, we don't have a T1 fat suppressed pre, so we don't know whether this is enhancing or not.
Okay.
And then you can see T2 down here. So it looks like a mass, right?
Mm-hmm.
It turned out this ended up being a foreign body reaction. And I forgot what the foreign body was in this particular case. This is from Korea, from Dr. Sid.
Interesting.
All right. 45-year-old male, 3-month mass, unable to extend. So there is a focal soft tissue prominence there in the subcutaneous tissues with a edema.
Okay.
Again, looks largely confined to the subcutaneous tissue. There's some extension into the fascia there too.
Maybe the muscles here as
Yeah.
well. Yeah. So what is it?
In keeping with the theme, maybe a foreign body reaction.
Okay. That's one thought. The trick here is this is from Victorville. And so whenever you're in California and you see a case in the inflammatory section from the desert, what's the first thing that should come to your mind?
Some atypical, mycobacterial.
That's the thing about, but cocci is really endemic to the desert areas of California, and this was coccidiomycosis.
Okay.
Elior.
Okay, 5-year-old male, inline skater with pain and swelling for 3 months. Okay, let's see.
We go back to Korea.
What I see this rounded lucency in the, kind of humeral metaphysis. Okay, there's multiple lucencies.
That's just a humorous. Yeah.
Yeah, and some thickening of that, maybe some periosteum thickening.
What's the first thing you think of?
I suppose infection. Could be like a Brody's abscess in the
You
metaphysis.
answered my question.
Yeah. Looks like there are multiple different areas of lucency, and you've got all this thick periosteal reaction. Maybe in the humerus, but I don't think the patient was laughing about it. And here's an MR scan shot, and here's an ultrasound shot.
Sure, the ultrasound, I think we see a fluid with a sinus tract going into the bone.
Right. You can
Similar.
see here on the MR, right?
Yes.
Some more images.
Yeah. Fragmentation of the bone looks like a fluid collection going into the bone.
Or could be coming out of the bone.
Yeah. Okay.
Okay, and then there we go. So your thoughts here on this?
Be worried about an abscess.
Okay. Okay. I don't know how well you can see this. Probably some miliary disease here in the lungs.
You're looking for TB.
Oh, okay.
Okay. I guess you might see some little stuff here. Okay, and here's an MR scan of the lumbar spine, all on the same patient here.
And there's soft tissue thickening along the anterior paravertebral.
So these have a name of being cold abscesses.
Oh yeah.
You go to the sagittal images. What does that look like?
Let's see. I see Is there edema in the vertebral bodies?
Yeah, so this is T1. This is contrast enhancement where some of the bodies become bright. And then we can see on the T2, those that enhance also have a little bit of edema in them. And then the diffusion weighted images also shows you've got edema within the bones there. So what's your diagnosis? And then we got a posterior element involved here, the little bit of probably a extradural abscess there. Extradural abscess.
Yeah, I'm still worried about infection. Yeah, well, Dr. You're is the TB, yeah.
Okay, so it's TB, and remember, TB is endemic everywhere, and it certainly actually is not getting better in the United States. So the characteristic things you get in TB is when it tends to be throughout the body. It loves the spine, and you get what are called cold abscesses, which is these abscesses that can be relatively painless without a lot of redness or edema around it. They tend to be very chronic and long-standing. So it's really kind of atypical infections. So when you start seeing infections all around the body, you really have to think some of the atypical infections. Because if you had this much staph or strep, the patient would be in the hospital, septic and probably dead. So
I've never made it.
yeah, so you have to really think about these, and they're not that, they're not that common. But on the other hand, every year we see cases of atypical mycobacterial tuberculosis and then in California, coccidiomycosis. So always remember that in your mind.
We're going to see more.
Yeah, probably we'll see more.
6 million across the borders in the last 2 years.
All right, so we have a 65-year-old left elbow pain and swelling, onset 1 year ago, exacerbation 2 months ago. Hep B positive, diabetic, hypertension.
Yeah.
Looks like there's a lot of soft tissue edema and swelling about the elbow, kind of posteriorly and medially.
Yeah, especially over here.
Well,
Yeah.
Swelling.
Right.
Yep.
You don't really know if it's edema. You can say it's swelling, but I'm not sure you can say it's edema.
Sure.
Okay. So what do you want to look at?
Like an MR.
An MR.
Ooh. All right. Okay, yeah, there's a lot going on there. Big joint effusion, a lot of debris, heterogeneous debris in there. Yeah.
Probably a lot of chronic synovial thickening here.
Edema in the bones.
Unfortunately, I'm going to have to give you this next image. I don't see the miliary pattern very well.
Yeah, I was gonna say I don't see that.
But whenever you see infection and somebody shows you chest X-ray,
It's TB.
it's TB. Yeah, so this is tuberculosis. A lot of different looks to TB, because especially if it becomes chronic.
A fellow named Hodson from China, the island, near Hong Kong, he was a world-renowned tuberculosis orthopedic surgeon. That's pretty much all he did. And one of my mentors spent a year with him, and it was unbelievable. The cases that were there, and the surgeries that he did without having prior book to look at. He had to invent his own surgeries, and so it's a pretty interesting story I heard over there. Korea is my place, but I didn't do surgery on these people.
Is that Pott's disease?
Pott's disease, yes.
Right.
He did a lot of spines,
Okay.
but he did everything, hands, spine, you name it.
Okay. Jason, what do you think of this one?
All right, so two things stand out. This is this ossicle or bone fragment, yeah, medially next to the medial epicondyle, and then there's this lucency laterally within the distal humerus. Uh, yeah, so the area that lucency does have some surrounding sclerosis on
How
the
would you describe that?
edges, and there's
I think
focal radiotracer uptake.
I would say it's an erosive change.
Yeah, a lot of bone edema.
Am I right, John?
Right.
Thank you.
Yeah, and the cortex definitely disrupted right there focally.
Yeah, this also is TB. So as you know, TB can basically look just about like everything. Okay.
It can fool you in many different ways.
Elior. Elior, are you with us? Did we lose Elior?
I haven't heard or seen any activity on Elior's.
He was with us a minute ago. Elior, are you on mute? Okay. Robert, why don't you go forward?
Sure. All right, so we have a 60-year-old female from the island of Molokai, polyarthralgia and rash, and it looks like there's diffuse soft tissue swelling throughout the upper extremity.
Is this modern technology?
Yeah, it looks like there's some destruction of that joint. It looks irregular.
So I guess you want an MR scan.
Yeah, absolutely.
Are you on it?
I don't know. Yeah, it looks like pretty extensive destruction of that joint. A lot of synovial debris and thickening and junk in there.
And was it caused by?
No, I'm not. I want to say
We have
TB.
lymph nodes here. Well,
It's
actually,
similar to TB.
actually,
Molokai.
do you know what
I
Molokai
don't.
is? Okay. Molokai was designated basically as a leprosy colony
Oh, in Hawaii. Right?
in Hawaii. That's what the skin looked like.
Oh, jeez.
And this is leprosy or Hansen's disease, which is still endemic in the United States, but it can be it's very hard to cure, but you can control it with antibiotics. So
It's endemic in Southern California.
yeah,
Armadillos.
Likes armadillos. And here you can see you can have bone destructive disease, which we've already seen chronically, and it's bacterium very similar to
Loss of
tuberculosis.
sensation and
Loves the
and,
nerves. Yeah. And you get neuropathic disease because it tends to affect the nerves, especially the pain nerves. And Father Damien was the person who started the leprosy colony in Molokai in the 1840s. And there's still a colony there today.
I don't think there is, John.
Well, I was told that there was the last time I was in Hawaii. You may be right, but I actually specifically asked someone that, and they told me
It's a very nice island. And that's what I've heard, but I've never been to it.
Yeah, I've never been to it either.
For some reason, I don't want to go there.
All right.
Redness and swelling 7 days. Looks like we have diffuse soft tissue edema, uh, maybe some fascial fluid as well. And kind of posterior uh, arm has some.
So
Is
there's
that some hemorrhage there?
abscesses here, and they're trying to make a diagnosis, so they actually operated on this patient. And they didn't find any pus there. A lot of whitish blacks. Cultures were all negative. This was diagnosed as necrotizing cellulitis without ever getting an infectious cause for it. Elio, are you with us?
Yes.
Oh, good. We lost you there for a minute.
Okay, 39 with elbow swelling. So I think it's a PD fat set on the top. We see fluid. I don't think it's from the joint. Looks like maybe the olecranon kind of bursa area.
Okay.
Is that a T2 on the right?
It's a T2 on the right, I think. I think it's a T1 on the left.
Okay. Okay, so that focal dark signal. I would expect the muscle to be there. Is there
Right.
disruption of the tendon?
This is a lot of edema within that triceps muscle, and this is all from a spider bite. Wow. And they can cause a lot of necrosis depending upon which spiders. Now, most spiders are actually poisonous, but the vast majority of spiders, the way their proboscis is situated, they can't actually bite humans. But those who can, they can produce a lot of necrosis, tissue necrosis. Yeah, I don't remember which one. I don't know if it says which spider this is, but I think there are three.
Black widow.
Yeah, certainly could be a black widow or a brown recluse, but I'm not sure.
There are a lot of
Brown
them.
recluse, I think. I think this was a brown recluse. Right.
Never stick your hand under a house where you can't see anything,
Yeah.
because that's where they hide out, in dark places. They don't come out to look at the sun.
All right, so we have a 32-year-old female, 1 month after burn. Looks like there's pretty extensive edema anteriorly there. And on these, maybe some fluid collections, rim enhancing.
Yeah.
So concern for infection, abscesses.
Okay. Could be infection. What else can you get with burns? Which means it's very important to diagnose this condition so it's properly treated before you get necrosis of the muscle.
Rhabdo?
Right. Well, the other thing you get is with burns, what you classically get is edema, which is caused swelling, which can then block the arterial supply to the muscle compartment, and you can get compartment syndrome.
Yeah.
And so this wasn't infectious, this was acute compartment syndrome with extensive muscle necrosis. John, do you want to talk to us about a compartment syndrome?
Well, the most common one is the anterior compartment of the lower leg, and the treatment is, if you think of it, you operate on it. That's the way I was taught. You make 2 incisions about 6 inches apart, and then you just snip the fascia from up down and from down up, and you release the pressure. It's not that big a procedure, and that's the cure.
Great. Thank you, John.
If you wait more than 24 hours, you're gonna have no muscle there. And if you operate 24 hours later, which is maybe too late, you have a very ugly looking leg with the scars on them. So once you go past that point of no return, don't cut it.
Okay.
Just leave it.
Thanks, John.
Welcome.
All right, so medial elbow, there's a subacute edema and some fluid collections within the muscle, I believe,
In the joint space.
and joint space.
A lot of synovial thickening.
Yeah.
What do you think this is?
It looks infectious, but
Could
could
be
be
infectious.
inflammatory as well.
Okay. This is pretty classic for rheumatoid arthritis. And again, this is the sort of thing that hopefully we won't be seeing now, but I'm sure we will. But again, this, when I grew up in medicine, this was really not a very treatable disease, and that really changed in around 1990. But we'll have a whole lecture on rheumatoid arthritis later.
This isn't a typical one, is it, John?
It's pretty typical. You get chronic synovial thickening, synovitis, and you can either have it with or without erosions. We need a good history to go along with it.
The thickening and the fluid is way up above. That's what gets me. It should be around the joint.
Up here, you mean?
And more down than up.
Yeah.
Because that's arm.
Yeah.
I think.
Okay.
Well, it would kind of need to do a little biopsy or something, some test.
Well, I mean, you could biopsy that, but I think that the workup would be more serological, and in a case like that, where you really make the diagnosis. But we'll talk about the current criteria for diagnosis of rheumatoid arthritis in another lecture. That's a whole lecture.
Yeah, I know it, so I won't say any more.
Okay. So, Taste, what do you think of this one?
All right. So it looks like there's a lot of marginal erosions on the T1.
Okay, so there's
And
an
then-
erosion there.
Um,
All this stuff around
yeah, a
here.
lot of synovial thickening. And is that the supinator muscle? That's the
We're right in that area.
yeah,
Yeah.
very high signal in that region. Again, maybe RA. So
Yeah.
best
So
guess.
again, this just shows marked distension of the joint space, marked synovial thickening with this inhomogeneous signal intensity on the PD fat sat. This is very characteristic of chronic rheumatoid arthritis, and this is erosive.
And you have an erosion, so
Yeah.
that clinches it, doesn't it?
It's very helpful. There are other synovitises that can produce erosions.
Yeah, I know.
That this is very, very characteristic of rheumatoid arthritis. Elior.
Okay, so here, yeah, we see a joint effusion, erosive changes throughout the joint.
Right. So we're just seeing more and more progressive disease. This actually was an erosion, and if we look at the sagittal, the axils, it actually goes right through the bone here. In this particular patient, here's all synovial thickening here, and then that's some fluid collection there. And this is just a more severe case of chronic rheumatoid arthritis. Now, we hope in this day and age we won't see any that look like this, but unfortunately we probably will.
Okay.
That tissue is really ugly looking when you remove it.
All right, so patient immediately drains olecranon cyst. It looks like there's a big lucent lesion in the olecranon. Can't see the overlying soft tissues, but there you go. There's a big cystic structure overlying that olecranons.
Yeah, so she was sticking a needle into this,
Got it.
which actually communicated with the cyst in the olecranon. Okay, so what's your diagnosis? And if we go here, we can see this is the same elbow,
Ouch.
looks similar to the previous elbows.
Yeah, so rheumatoid arthritis.
This is, again, a case of rheumatoid arthritis. That the patient just didn't see a doctor and get a diagnosis till it was at this stage.
All right. So there is effusion. Looks like a lot of destruction of the articulating surfaces there. I mean, I think this is. There's not a lot of synovial thickening on this one.
There's some synovial thickening in through here, but
The periarticular
not as
erosion, I
common
would
as
feel like
this.
it's like hemophilic or
well,
something.
this really involves the articular surfaces here,
Yeah.
which is a little bit atypical for rheumatoid. Rheumatoid, the erosions tend to be on the periphery, and we'll explain why when we talk about rheumatoid arthritis. But this was a patient, and you're right, this is really the articular surfaces, so this has a broad differential in this case. This certainly could be infectious or post-infectious degenerative disease. Could be trauma. This happened to be end-stage rheumatoid arthritis.
Okay.
Elior.
Okay, so history of lupus, multiple 1-month-old masses. Okay, on the, I think it's a T1 in the top left, these rounded lesions in the subcutaneous fat, they look bright on the PD fat sat. Well, they're dark in the center and they have this rim,
Right.
bright signal.
So this is lupus paniculitis. It's a autoimmune inflammatory process within the fat called lupus paniculitis, and that's what it looks like on an MR examination.
All right, so we have a 52-year-old set in pain and swelling of the right elbow, CRF, dialysis, concern for septic arthritis. Don't know that I see a whole lot here.
A lot of renal disease. Okay.
All right, that's more like it. So there's a joint effusion, some synovial thickening and enhancement.
Okay. Let me go back here for a second.
Okay.
Okay. Probably an effusion here with the fat pad. The patient went to arthroscopy, and this is what they saw at arthroscopy.
So this gout.
Yep. These are the clumps of uric acid crystals, which you can see in the synovium there, and all this synovitis and fronds and so forth. Good.
50-year-old with elbow pain. Looks like we have some complex fluid in the olecranon bursa.
Okay. Yeah, maybe a common extension.
Yeah. I mean, gout should be considered in
Okay.
this, yeah.
This is kind of a funny looking speckle type collection here, and it's fairly typical of gout. I wouldn't call it diagnostic, but it should make you think about it. And this is another patient with gout. Olecranon bursitis is one of the more common places. And I think I told you guys when I went and lectured at MGH many years ago. Did I tell you that story? Oh, well, I used to, in those days, they were the very early days of laptops. They were big clunky things. I tried to work on the plane when I went to give lectures, and I flew to Boston, and but my elbow started hurting in the middle of the flight because I was resting it on the hard uh, armrests on the plane. I was doing a lot of working on lectures in those days, and I went up to give my lecture, and I guess it was warm in the room, and I kind of rolled my sleeves up, and you could see this big swelling on my my elbow, and somebody in the back of the room raised their hand, and I called on them, and they said, "Dr. Crues, you've got gout." And so, I haven't seen it that often, but I've always remembered that this is one relatively, I guess, common location for gout. Though I haven't seen it all that frequently, but this is pretty typical of gouty bursitis of the olecranon. I ended up not having gout. It was just from pressure lesion, and I had a venous hemorrhage into the olecranon bursa, which caused pain in my situation.
Hemorrhage and infection is far more common than gout.
Yeah,
I think
I think so.
I've
No
taken
rest your
up quite
elbows
a few of those.
all the time on a hard surface is my
I had I don't know, I don't think I told you this story. If I have, let me know. But I had a doctor come to my office, and he had a bursa that's hot and painful. So I aspirated it and got a gram stain and got a anaerobic, aerobic cultures, etc.
yeah.
And put him on antibiotics, and his temperature was about 106 or whatever. And I said, if your temperature rises and if it hurts more, you're going to the hospital. He didn't want to go. He was a stubborn guy. So I got a call a couple hours later, and his temperature was 103, 104. And I got my partner to call them, and we got in a car, I went, picked him up, took him to the hospital, and went right there to the operating room and took out his bursa,
Oh,
and he was cured.
oh my gosh.
But that was pretty scary there for a while
Right.
because he was getting toxic,
Yeah.
and he was an alcoholic too,
Hmm.
which didn't help.
Who's next?
I think earlier.
Okay. Eliar, what do you think of this one?
Chronic elbow pain in the olecranon bursal region. We see this soft tissue. There's erosion into the olecranon and maybe a tear of the triceps tendon.
Okay.
So this looks like gout as well.
And what's the finding here that makes you most comfortable that this is gout?
The involvement of the tendon and the erosion.
I think that's right. But it's the characterization.
Insertions.
Yeah.
Yes.
Right. The insertion. That's classic location for gout. This soft tissue thickening is very characteristic for gout. It's not really fluid here. We just have this marked synovitis. But the thing that's really characteristic of the gout that I haven't really seen in any other erosive changes is you get these spicules of bone that are very sharp. Almost every other disease, when you get an erosion of the bone, everything, all these potentially sharp angles get smoothed out. And you can see a nice sharp little spicule of bone here. With gout, it just loves to have these little margins of sharp spicules of bone. So when you see that, you've got to be very concerned about gout. And we'll see it in other joints, especially when we get into the feet as well. So this was gout.
All right, so we have a 41-year-old right elbow pain and swelling for 1 year. Looking at the olecranon, Looks like there may be some erosions and soft tissue thickening in that region. Yeah.
Goes all the way to the skin.
Yeah. Yeah, that triceps tendon also looks like increased in signal and some erosions there at the olecranon.
Yeah.
Another gout.
Triceps insertion.
Yeah.
Mm-hmm.
And see how these little sharp spicules of bone here?
Mm-hmm.
That's very characteristic of gout.
All right, roll out biceps tear.
Actually, let's stop here. This is a good place to stop. And we'll start up here and we'll finish the inflammatory section next week and then move on to another topic. Okay?
All right.
Thanks.
Okay, have a great weekend, everybody.
All right.
Thank you, guys.
Thanks.
And stay out of trouble. If you get into it, make sure it's worthwhile.
And call Dr. Yagutis to save you.